I just want to thank you for coming to join us. Tom is one of the most compassionate, patient-centered physicians there is, and we are grateful to have you here with us today. He is a long-term friend of NCCS and of Ellen Stovall, and is a past awardee of the Ellen Stovall Award for Innovation in Patient-Centered Cancer Care. And he is incredible to share both his clinical expertise and his personal experience. And I'm just going to turn it over to you. Thank you.
I'm from the Midwest. I'm not used to shouting, so. I should also say I'm also a prostate cancer survivor with metastatic prostate cancer. I'm sort of in between treatments right now. I'm on a clinical trial to see if forced weight loss reduces cancer cell growth. And I randomized to the control arm, which means nothing. But I'm staying away from the cupcakes. So I wanted to talk about supportive cancer care. This is really a 40-year journey for me, also known as palliative care. Palliative care rubs some people the wrong way because every people associate it with hospice. It's sort of how I got to where I am today. And for those healthcare professionals, you work to make the type of healthcare you'd like better and more affordable. And I'm going to talk about our cancer outreach program for Massey Cancer Center, the palliative the palliative care unit we set up at VCU MCV and then at Johns Hopkins for healthcare providers and really for everybody. Bring your whole self to the therapeutic encounter. It took me a long time to realize that talking to a healthcare professional is really a therapeutic encounter in and of itself. It's not just giving the drugs. That's what most oncologists like to do, is just give the drugs, please. And Ira Byock said, well, if you can joke, make a joke. If you are comfortable with sharing spirituality, go ahead and share that. Emphasize communication, have fun along the way, always keep researching. There's lots of room for symptom assessment and management to improve. And some pearls, including the first one. Some of you may know somebody who has had hot flashes. I figured in this room there would be a few. When my cancer came back the first time, I got androgen deprivation therapy, which dropped my testosterone to 0, and then 8 weeks of radiation therapy. And I got hot flashes like crazy. I mean, I'm a terrible runner, but I am a championship sweater. So I would wake up at 2 o'clock in the morning. It's actually 2:45 every morning, drenched in sweat. And then every 45 minutes, I would basically be drenched in sweat. And we tried all the things that work for female hot flashes. I should add that I'm a breast cancer doctor, and I've put so many people into early menopause, I figured it was payback. So we tried venlafaxine, we tried gabapentin, we tried a couple of duloxetine, a couple of other drugs. Nothing worked. I was about to do a do-it-yourself stellate ganglion block where you stick a needle back here behind the neck when my friend Charles Aprinzi said, well, why don't you try oxybutynin? And the hot flashes were really terrible for me because they kept me up every night. And there's nothing like 6 months of completely interrupted sleep to make you pissed at the world. Plus, I would have to take four changes of underwear to my office. And during the day, I'd be stripping down, changing my underwear, wait till they went away, and then put my clothes back on. So within 2 hours of taking my first dose of oxybutynin, which is Ditropan, it's for bladder spasms, and it's for people who sweat too much. It stopped my sweating. Didn't stop all the hot flashes, but it stopped most of my sweating. So I was having lunch with the editor of the New England Journal, who's an old friend, Dan Longo, and he said, well, you should write this up because nobody knows about it. So we actually wrote a letter to the New England Journal back in 2018 just describing it, and went on to do a trial for women with hot flashes because they're easier to find and easier to recruit. And this is the placebo arm, and this is the group that got a half dose of oxybutynin, and this is the group that got the full dose of oxybutynin. And that number is the number and severity of hot flashes. It's become my go-to drug for them. And it really, really works, has very few side effects, it's very inexpensive. You might get a little dry mouth, that's why I eventually stopped taking it, but it's worth it. We even use it for people who have fevers due to their cancer. I sent a prescription to one of my patients, and 4 hours later she emailed me back that, oh my gosh, that helps so much, because every night at 8 o'clock she would just break out in a sweat for a couple of hours, and it just wasted her evening and made her life terrible. All right, so this, starting out as a young oncologist, I remember sitting down with my late friend Chris Desch, oncologist who died in a plane crash back in 2006, and two nurse practitioners, Cindy Simonson and Nancy Kane, and we looked at a map of Virginia. And these brown areas are where people have excess mortality time trends, meaning your chance of dying there is a lot worse than anywhere else in the state. And it mostly correlates with where African Americans live, or poor people. So no health system in its right mind would say, I'm going to start a program that goes to a place where I know most people don't have insurance, or they have Medicaid or Medicare, or are underinsured, but we were young and stupid. So that's exactly what we decided to do. Because if you get diagnosed with cancer out here in Kilmarnock, and it's 100 miles into the cancer center, it's going to be, you have to stick with the surgeon who's there locally, who may not be well trained. You can't get your chemotherapy, plus then you have the 100-mile home drive, hanging out the window. And some of the benefits. So we wanted to provide state-of-the-art palliative care. Clinical trials, always part of it. And we just did palliative and hospice care as part of oncology. It's just something we did. So we went to, the first one was down at Community Memorial Hospital in South Hill. That's the tobacco belt down there. And then Greensville Memorial, this is sort of the peanut belt of Virginia. And then Rappahannock General Hospital in Kilmarnock. And then Southside Community Hospital in Farmville. So we would drive down to Community Memorial, spend a day seeing cancer patients there, come up to Southside Community, then the next day go to Rappahannock General, and eventually make it down to Greensville. We even had a spot out in Grundy, which is about a 5.5 hour drive. And we would see the patients once, say they needed treatment after their breast cancer surgery or colon surgery. And we'd set up the treatment for them, and then one nurse out there would administer basically everything. It worked perfectly well. So there's a much younger me. It was an experiment. We had a private donor who bought the van for us, and a limited state budget. And we went to these 5 hospitals. But more importantly, we took 3 to 5 nurses from each of these rural hospitals and brought them into MCV, VCU, and trained them to be oncology nurses. So they spent 1 to 2 weeks up on the oncology floor in the outpatient clinic, learning about chemotherapy, learning about emergencies, and they got really good at it. We did the same for a couple of internists and family docs from each of the places. And it always included palliative care. So here's some of the results. When we started at all these rural hospitals, nobody got a lumpectomy and radiation because the surgeons didn't know how to do lumpectomies, and radiation was 110 miles away, one way. So imagine how much that disrupts your day. So we had Walter Lawrence, who was one of the world's best surgeons, come down and teach how to do lumpectomies, and then we hired a van that would leave the parking lot at 6 o'clock, drive up when there's no traffic. The patients would walk right into the radiation therapy area. They'd all get first dibs on the radiation machines, get right back in the van, and they'd be home by 9:30 or 10 o'clock. Wow. So, and we went from about 25% of eligible patients getting adjuvant therapy to close to 100%, partly because these nurses knew where everybody lived, and they could track them down. And there was still, at this point, 30 years ago, places in Virginia that didn't have running water or indoor plumbing. So marked reduction in vomiting and nausea. Morphine increased 700% for cancer pain. Before that, people would just give huge doses of tranquilizers so the person couldn't speak. And it turned out to be highly profitable for rural hospitals. Not only did it save 1 to 2 million miles of patient travel a year, it generated $1 to $2 million of profit for these rural hospitals, which then let them keep their ED, emergency department, open. It let them keep their OB department open. It enabled them to buy an MRI machine. So it turned out to be sort of a win-win situation for everybody. There is a lot of distrust in the healthcare system, much of it earned. A lot of distrust of old white doctors who are privileged, as my wife would say. And when you go into a community, you have to earn the trust. My wife and I learned this, first of all, going to an Indian reservation in North Dakota. The fact that we'd gone to Yale Medical School and the University of Pennsylvania for residency didn't mean anything. The fact that I could help women with their arthritis because I was an internist and raise some people from their graves, that made all the difference in the world. So you take care of somebody's brother, their daughter, their sister, their auntie, and you get trust in the community, and then you can start doing things that make really good long-term sense. So we went into the schools and started the Schools for Health program to teach young kids that exercise is good, that eating vegetables and fruits is good, cutting down on red meats is good, and that program's still actually going. So for those of you who, how many of you are Cupid students? Okay, I know some of you. Some advice, find some role models. This is Galen Wampler on the left, lung cancer doctor, and he was a man of very few words, Mennonite man. He might go through the whole visit saying 25 words to the patient, but he would listen really well. And he would say, if they want to know what's going to happen to them, go ahead and tell them. People deserve to know. And everybody's nodding their head, but it wasn't as common 25, 30 years ago. And then my chief, David Goldman, said, don't worry about promotion, just find something that you're interested in and go ahead and do it. That's much more important and much more satisfying to your life. And then Susan Millett, who was one of maybe the first female medical oncologist, was a heavy chain smoker. So you go into her office and you'd cough for a couple days afterwards and smell like cigarettes. But her advice to me, because she treated people up to the very end, often with really tiny doses of chemotherapy. And she said, Tom, you got to use some of these new drugs before people show they don't work. Still good advice. And have some fun. There's me dressed as Dorothy. We had a baseball party every year for the whole clinic. We cooked 120 hot dogs. We bought season's tickets to the Richmond Braves, a AA team. Everybody on Friday afternoon converged in the clinic and it was a covered dish supper, essentially. So you could get 6 different types of potato salad, and you didn't have to go to church for it. Find some pursuits. This is me running the 100-mile Umstead Run, and that's Kara Corbett, who I paced a couple of times. So And for those of you early in your careers, find some colleagues. Find some people who think like you. Maybe there won't be any at your institution. You might have to look hard. But I found June Dahl at the University of Wisconsin, Diane Meyer at Mount Sinai in New York. And then there were a group of 3 oncologists here, along with myself and maybe 1 or 2 others, who tried to convince the American Society of Clinical Oncology that being honest with people, paying attention to their symptoms, relieving their symptoms is really important. Like stopping somebody from throwing up is probably just as important as them getting their chemotherapy on time, because they may not come back to get their chemotherapy. We were called the lunatic fringe. And luckily, it's become mainstream. So we'd set up that program, and we got a grant to see if we could change palliative care and hospice use by minorities. We knew from doing a large study across the state that the people who used hospice were more likely white, married, higher socioeconomic class. Where are the billboards for hospice? Are they in the inner city? No, they're out in the suburbs where people have disposable income and can afford this. And so at that rate, African Americans used hospice at half the expected rate. Hispanic Americans about half the expected rate. And hospice has some really good attributes. People who use hospice get much better control of their symptoms. People who use hospice live 1 month longer than those who don't. Isn't that surprising? Because my colleagues will say, oh, hospice just drugs them up and kills them. And I say, no, that's not exactly right. In fact, they pay attention to the person's pain needs and sometimes can reduce or substitute pain medicines. And in fact, several studies show that people who use hospice live longer. And if you're of Medicare age and your spouse dies, your chance of dying in the next year is pretty high. It's 13% if you're a woman, 18% if you're a man. And if you've used hospice, the rate of death is cut in half of the surviving spouse because there's so less stress, more satisfaction with the process, less stress, and some bereavement work that goes with it. I don't know why men die more than women. I think they either, bleed out after cutting themselves opening a can of sardines for dinner, or they trip over the clothes that should have been in the laundry hamper and break their hip. So it wasn't clear whether it's trust, opportunity, mismatch of goals, perceptions of the healthcare system. So we started to teach about palliative care. And this is the Center to Advance Palliative Care's definition. Specialized medical care, relief from symptoms, pain, and stress, whatever the diagnosis, provide an extra layer of support, and it can be provided together with curative treatment. We now see everybody who gets a heart transplant. We see everybody who goes on an artificial heart. We see increasingly the leukemia patients and bone marrow transplant patients, because what's wrong with having somebody or a team of people, a chaplain, a social worker, a nurse practitioner, a nurse, a doctor, some group of them, sit down by your bedside and say, tell me how you're doing. Tell me how you're coping. And people will tell you, and they'll say, well, I didn't have a chance to tell my doctor that I had diarrhea 4 times last night, or that I'm really depressed, or that I'm really worried about my 3-year-old. And if you bring those things to the fore, you can actually do something about them. So I think this is my elevator definition: expert symptom assessment and management, open and honest communication, and medically appropriate goal setting. And people who use palliative care alongside cancer care actually live longer too. So we did one study up here where we randomized 200 people to get the red line is the very best pain management that you could get. And the other was the very best pain management you could get plus a pump that puts little tiny amounts of painkillers into your spinal fluid. And the difference at 6 months in survival was 17 people out of 100. So if you got your pain relieved, the difference is 15 to 17 out of 100 at 6 months. Really pretty remarkable.
Where did you place that?
You put it under the skin here, and then it's tunneled underneath, and it goes in between L3 and L4 right into the spinal canal. And so it's just floating free. Anybody had an epidural, it's the next closest thing to an epidural. So this is the study that got people's attention because it got published in the New England Journal of Medicine. Jennifer Temmel at Mass General randomized 157 lung cancer patients to their usual care, which is really good at Mass General, or the usual care plus seeing a palliative care person once a month. And the palliative care person, the 60-minute initial visits, spent 20 minutes on symptoms, 10 minutes on illness understanding, 15 minutes on coping. So I always ask people, how are you coping with this? I wish people had asked me that during my various travails. And people who saw the palliative care team had better quality of life, a much better understanding of their prognosis, and despite that, they had half the rate of depression and anxiety. So knowing what's going to happen actually cuts down on anxiety. We also know that if anything, it improves hope. It doesn't take away hope. If you measure hope, as we did in one study, hope actually goes up the more you know about what's going to happen to you. And almost 3 months longer survival really got everybody's attention, because there are now a whole bunch of studies that show the same thing. These are people with refractory breathlessness. These are lung cancer patients at City of Hope. The purple palliative care star is always on top compared to usual care. So what's not to like? One modern day adaptation to that is give people an iPhone or a computer and have them check in once a week by symptoms. So electronic symptom monitoring. So Ethan Bosch randomized 766 patients at Sloan Kettering, another good place to get your cancer care. And this group, the yellow line, once a week they would report in on their symptoms, and if the symptoms spiked, then the nurse would call them up and either bring them in or try to fix it by phone. And the difference in survival was 6 people out of 100. That's a lot better than a lot of the drugs we're paying $12,000 a month for. He did the same study in sabbatical in France with lung cancer patients, same once a week check-in by electronics, or you could check in earlier if something went wrong. And it was 12 people out of 100 alive if they did that compared to the control group. 12 people out of 100. So the other thing we do is we ask about symptoms, and we always use a checklist. Are you bothered by pain? Are you bothered by fatigue? Are you bothered by nausea? Are you bothered by depression? Are you bothered by this old privileged white guy coming in and asking you the same damn questions every day? That usually gets a laugh. But people tell you, if you just say, how are you? They'll give you 1 symptom. If you use a checklist, they'll give you 10 symptoms, half of which are fairly distressing. So it's simple and easy to implement in any practice. So we created the Thomas Palliative Care Unit at Massey Cancer Center, and of the first 237 patients, 56% were African American, exactly the same as the rest of the hospital. And it turns out that having established that trust relationship allowed people of all stripes, of all genders, to actually use palliative care and then transition to hospice when needed. So it's one simple solution by establishing trust, establishing trust, establishing trust. And part of that you do by fixing symptoms. We actually had the highest satisfaction rates in the hospital, and we relieved symptoms. These are common symptoms that people had. They all went down. So we showed that people lived exactly the same amount of time. Their symptoms went way down at 24 and 48 hours. They were much more satisfied with their care. Their relatives, even if the patient died, their relatives were much more satisfied with their care than the rest of the hospital. And it saved money, which was never the intent. But taking somebody out of the ICU at $7,000 a day, now it would be $12,000 a day, and putting them in the palliative care unit where you are surrounded by loving people who are mature, self-actualized nurses who will take great care of you, and there's a social worker on the floor, and the chaplain comes, and the therapy dogs come several times a day. That costs like $2,500 a day. So the cost went way down, much less than the average reimbursement. And when we first published this, you'd think the response would be, oh, great. But it was, oh my God, people are going to think we're throwing grandma under the bus in order to save money. And so we had to devise a slogan. So we actually hired a social marketing firm and came up with a motto. It's just better care at a cost we can afford. So that one seemed to play pretty well. So there's this cost avoidance. In the first year, we saved the healthcare institution about $2 million. So 10 years ago, I talked about communication. You communicate where it really matters. Got a phone call from the Wall Street Journal. Could they send a reporter down to hear about this? And so Gautam Naik came down, spent 2 weeks with us. He made home visits with us. He saw people die with us. Luckily, he was a terrifically nice guy. And with the analysis that we did for them, for the Wall Street Journal, was you save about $7,000 per person. And this appeared on the front page of the Wall Street Journal above the fold, which is as good as you can get. It even had one of those little sketch drawings of my face, and my beard was red at the time, and so it made me look like Ahmed the terrorist, which I still get comments on. But I'd been out at the country for a couple of days, and when I got back on Sunday morning after meeting to my office, there were 3 CEOs or CFOs who had called and said, how can you teach us to do this new palliative care thing? It wasn't the clinical people calling, it was the CEOs and CFOs. And it gave us a boost, enough of a boost to advance the field. So we did it at Hopkins, the same sort of analysis. And the first year we saved the system close to $4 million. Now it's probably $12 million. And we co-opted the people in the finance department. Most of the authors here are from finance, including the head of finance for Johns Hopkins University, who has an interest in palliative care. So he believes it. It makes me easier to walk into the CEO's office, Redonda Miller, and say, Redonda, I think we need another nurse practitioner. We now see about 10% of the patients in the hospital. At a 1,000-bed hospital, our list yesterday was 99 people. So what does palliative care really do? What do we really do? We do symptom management. I ask people, what's your support system? Who's your support system? And if it's pretty thin, we try to flesh it out with whatever resources our social worker can find. Advanced care planning, and we have the tough conversations. This is a tattoo that says, how do you like to get medical information? Are you the sort of person who wants all the details or something else? And people will tell you, 10 to 15% of people don't want to know the details. And if you wade in like I'm used to doing, you destroy that trust relationship. And then the most important question, what's your understanding of the situation? Works at home too. Honey, what's your understanding of the checkbook situation? Number 3 is what's important to you. Number 4, what are you hoping for? And if people say, well, I'm hoping for a miracle, we can say, that's okay. You don't say, well, it ain't happened yet, so probably ain't going to happen. But that doesn't do anybody any good. We actually interviewed some patients in front of Ken Burns for the emperor of all maladies. So we had grand rounds, and we just titled it Hope. And we had 3 people come in and for 8 to 10 minutes each tell what they were hoping for. And one of them, and then I got to interview somebody and tell her bad news in front of the grand rounds audience. I'd clued her in somewhat. So I asked her, what are you hoping for? And she said, I came to Johns Hopkins for a miracle. So we actually wrote a paper. I did a timeout like this. And I said, Reverend Rhonda Cooper, come on down. And there was a big whiteboard there. And she started to write. She put a big A, M, E, N. This is how you remember your response. Amen. Affirm. You can say, I hope you get a miracle too. And then M, meet them where they are. E for educate. You don't want to say, yeah, you could get a miracle, but that puts you in direct opposition with God. And you, as Rhonda would say, you're going to lose that most of the time. So you say, I'm hoping for a miracle. That's God's province. And my province is, part of my job is to tell you about the medical options that we have. So it's education in your usual way without feeling threatened by this. And then N stands for no matter what. We will be with you no matter what. Amen. We published this in the Journal of Clinical Oncology, and it was the most downloaded article for about 6 months. So it obviously struck a nerve. Amen. Amen. And I have some tattoos here. I didn't bring enough for everybody because I'm out of them. The maker, Straight Tats, went out of business, so I don't have enough of them. But particularly if you're a healthcare provider, the Cupid people, I can get one for at Hopkins. Now some fun things. So this is something called scrambler therapy, which is, guess my video is not going to work there. Those are my feet set up to treat chemo-induced peripheral neuropathy. And those are EKG electrodes. I hear some of you saying, oh God. It's the bugaboo of modern day chemotherapy because nothing works very well for it. Duloxetine or Cymbalta helps a little bit, but a little bit, a very little bit. And it's disabling for some people. And it keeps you up at night. And it makes you depressed. And it is a constant friggin' reminder that you had cancer. So it puts you in that PTSD spiral every time you put the feet down on the floor. So those are my feet set up to treat there. You're running a series of impulses there. They're made to look like how one nerve talks to the other, like a pain signal, because those damaged nerves are sending a pain signal. But it's not pain. It's felt more like being bitten by little tiny electric ants. And it varies, it varies. It feels a little similar to a TENS unit if you've ever used one of those. And this was a pretty typical case. Her pain was down here on the feet, but she had nerve damage that I could assess all the way up to here. So the electrodes are on different parts of the leg. Her pain went from 5 down to 3. The next day it had come back up to 4. It went to 0. Day 3 it was 0. 6 months later it was 0. 12 months later and 18 months later it was still close to 0. Doesn't always happen that way, but probably 60% of people get significant relief from it. Yes?
Sorry to interrupt. I have a question. I am a colon cancer patient survivor. I have crippling neuropathy, like all of my arms, like my feet is a hot mess. Cymbalta and what's the other one? The third one. Thank you. That doesn't work. I was recommended this. I did not follow through with this because I went to a private community cancer center. I was referred to our medical cancer center, NCI, where I live. In order for me to have access to this treatment, I was expected and required to pay $3,500 up front out of pocket because my insurance wouldn't cover it. However, they preceded the ghastly cost blow with saying there's a possibility that it might work for you 5% in order to help you with your neuropathy. Is that something that you can debunk for me so that I can probably try? I'm so scared to throw all this money on top of everything else for something that's not going to work.
A lot of places are doing that because if you bill it as an expensive procedure, a lot of times insurance won't pay for it yet. United is starting to, because there wasn't much evidence before recently. I'm in Baltimore, and I just charge people a regular doctor's visit, so it's like seeing any of your other doctors. I don't charge $3,500. So I know you could do this because I've been involved in pain research a long time, and you can put electrodes along the spinal cord with a little charge generator, and you reduce pain scores by 50 or 60%. So you know you can do it electrically. This is just the first way to do it electrically that doesn't involve sticking needles into your brain or spinal cord, as cool as that is. So the last trial we did with us in Mayo Clinic, we saw a 60% reduction in pain and a 50% reduction in numbness and tingling, oftentimes persistent. Some of my people have to come back at 2 months and 4 months and 6 months, but it only takes 1 or 2 sessions to get them down. This is a guy with HIV neuropathy, and he couldn't stand and close his eyes because he couldn't feel the bottoms of his feet. And it hurt too. It was numb and it hurt, which doesn't make a whole lot of sense except the numbness is caused by a different set of nerves. But this is him on day 3 doing the crane pose. If we had turned off all those pain and numbness signals so that he could actually walk again, and he's now probably 10 years out, at least 8 or 9, and still doing fine. This is a post-mastectomy. Some people have post-mastectomy pain. She said it felt like a barbed wire bra across her front every day. Again, puts you right into that PTSD spiral. We're batting about 90% with this. You can see her pain scores went down fairly quickly. It came back at 3 months, so we had 1 or 2 treatments, and then it stayed with her till she died about 2 years later, the pain relief. And for scar pain, like this woman had a thoracotomy or lung surgery scar, her pain was relieved in 15 minutes, and it lasted 5 months. And then we retreated her, and it got better again. So the closer things are to the skin, the easier it is for this machine to capture the nerves. So I think this is the future. This is shingles pain. The inventor and I put together a series of 10 people, 95% reduction in pain at 1 month. Yeah, it's crazy, but it works so well. This is a terrible disease called neuromyelitis optica spectrum disorder that happens in young people where the immune system attacks your retinas, so you go blind, and then it attacks the lining around your spinal cord. So you get this terrible burning electric pain, like here, down to there, that part of his neck. And we did a randomized controlled trial. We used a sham, which people couldn't tell was a sham, and that didn't help. But people's pain scores went from 5 down to 1.5, and stayed there. The other cool thing we're doing is auricular point acupressure, which is an old Chinese remedy. We have an open clinical trial, so send me an email or call me. We have an open clinical trial. Everybody gets treatment. It's just we're using one group where we teach you how to put them on in person, and the other, we try to do it by video. Because if you could do it by video, you could do it anywhere in the world. So you get these little tiny flower seeds from this flower, stick them on sticky tape, put them there, and then on the back of the ear too, and you press them for 3 minutes 3 times a day. And that's my ear during chemotherapy and radiation. I know it helped me because I felt so much better in 45 minutes that I was able to actually go to the gym, which I hadn't been for a long, long time. And the first 15 people we did, we saw dramatic reductions in their pain, numbness, tingling, and stiffness. And this continues to be my experience. It's safe, it's simple, it's easy. If you want to be part of the clinical trial, it would require 4 visits to Hopkins over the space of about 6 months. And it resets your inflammatory system, which is really cool. So we measured people in their high pain state, and their pro-inflammatory compounds were way high, and their anti-inflammatory compounds were way low. And then after, a month later, it had reversed. Things were back to normal. So getting rid of the pain restores your inflammatory system to normal, which has to be good for you. We saw the same thing with scrambler therapy, by the way. It even improves function in the brain. So we had 8 brave people who went into the MRI machine, and we measured what parts of the brain were talking to one another. And the blue parts are what should be talking together for memory and executive function, and then for pain control. So the brain looks like it's healing itself. All right. A couple of lessons I've learned from brushes with serious illness myself. I've talked to oncologists' office about what they can learn from their own health experience. My first was when I discovered I had a bicuspid aortic valve. So that's me finishing the Umstead 100-meter run down in the North Carolina mountains. And I had a cough afterwards. I have exercise-induced asthma. So my wife insisted I get a chest x-ray, which purported to show a nodule in my chest here on the plain x-ray. So I got a CAT scan. And the CAT scan showed not only did I have lots of calcium in my valve, but it looked like this instead of like that. It should have 3 valves, and mine only had 2, or 2.5. And my aorta had really ballooned out, and that's not good. In fact, the cardiac surgeon I saw down at VCU said, well, we ought to operate on you next week because you're young and healthy, you'll survive, and we're going to have to take out your aorta, put in a Dacron one. Your running career is over probably, but that's what's recommended. So I went and got a second opinion. Luckily, one of my med school classmates was Duke Cameron, who's the world's expert on aorta problems at Hopkins. So I drove up to Hopkins and saw Tom Trail, because this was what I was worried about, right there. That's a scene from Alien. I was worried about this bursting out of my chest and my family having to put up with it. You see how surprised these people look? The director didn't tell them this was going to happen. So they were, in fact, surprised. They were very surprised. So I asked people, what are you most afraid of? To find out a little bit more about them. And I was afraid that this was going to burst open and I'd be dead and probably embarrass my family too. So I saw Dr. Tom Trail, who's a cardiologist at Hopkins, lovely English accent, master cardiologist, who said, well, in my experience, you'll almost certainly die of something else. So I'll almost certainly die of prostate cancer, but he was right. And it turns out that at the Mayo Clinic, they followed 212 people who had valves like me, and not a single one of them acted like Alien. Not a single one. It turns out it's a metalloproteinase deficiency, and you get this partly bicuspid, partly tricuspid valve, and you get the aorta expanded beyond it, but it's not a damaged aorta, it's a perfectly normal and pulsatile aorta, and it just doesn't burst. So I ask now, what are you most afraid of? And then I'll ask, how are you coping? How are you coping with having your world turned upside down? And people will tell you. And it's the only way you're going to find out. They'll say, I'm so worried that my 3-year-old won't remember me. I'm so worried that my 9-year-old will have trouble going into middle school because he doesn't have a mom or dad. I'm so worried about blank. which you'd never find out without asking. And then remember just to ask, how are you coping? So what I teach oncologists is to look the patient in the eye and say, how are you coping? Listen to the answer, and then physically turn and look at the family and say, you know, Aunt Maud's pretty sick. How are you coping? And they'll tell you, we can't afford the $15 for parking every day if you want us to come in every day. And we've used up all our parental leave. Is there any way I could see a social worker to get some help with finances? I've got all this financial toxicity. You know, the drugs are $24,000 a month. I can't pay for them. So they'll tell you. So I've gone ahead and run. I've done the Mountain Masochist 50-miler 5 times. It's an aptly named run. Baltimore Marathon 6 and the Richmond Marathon at least 20 times. And the Catoctin 50K. And the most interesting run was rim to rim across the Grand Canyon and back in one day. So make sure you have a big backpack for water, a big Camelback. I had an 80-ounce one, and I filled it up 4 times going and coming. So the other thing, particularly for healthcare professionals, but for everybody, is mental illness is so common. Depression, anxiety is so common. It's just gotten worse in our political environment. It's just gotten worse with this thing called COVID. People just are doing crazy things. And I got really bad depression when I was a resident. I went from being top of the class to somebody who couldn't come out of the house in about a month and a half. And everything looked completely gray. No pleasure in anything. And it was bad. It was bad. I didn't have suicidal thoughts then, but I probably, if I'd continued, I would have. So when I talk to healthcare professionals, I'll give them some navigation points and say, medications and talk therapy really work, just as well in cancer patients as anybody else. And I found a good psychiatrist after having had a bad psychiatrist and got on a second type of medicine that really helped, trazodone, and really solved my depression in about 3 weeks. So this is my note for physicians. If you listen carefully to what patients say, they'll often tell you not only what's wrong with them, but what's wrong with you. And it made me a much better doctor, made me a much better listener, made me much more tuned in to asking, are you depressed? Have you felt depressed most of the last 2 weeks? It's a simple and easy question, and yet it doesn't get asked. Oncologists rarely ask it. So fast forward 40 years, I'm on androgen deprivation therapy. I have hot flashes out the wazoo. I'm sleep deprived for at least 6 months. I had a TIA or mini stroke as a result of therapy. My lungs failed. The chemotherapy damaged my lungs. So my running career was over. You know, my lung function was about 50% of normal. So I got short of breath drinking a glass of water rather than running a marathon. It's gotten a little bit better, but not a whole lot. And I got put on duloxetine for hot flashes, and I saw a psychiatrist raise it up to 120. And that turned out not to be the right thing for me, because I think the combination of my depression and the duloxetine made me suicidal. So I had the tree picked out. That's how suicidal I was. And I didn't want to, join Chester Bennington from Lincoln Park, Dolores O'Riordan from the Cranberries, Kate Spade, Anthony Bourdain, some of my favorite musicians. Luckily, my family intervened. I got hospitalized for a week. 24 hours off the duloxetine, all the suicidal thoughts went away. And I'm not sure if that's cause and effect, but it was pretty impressive to me. And I'm seeing a very good psychiatrist now, and my depression's well treated, my anxiety's well treated. So don't be afraid to do this. I didn't get thrown out of my job. I didn't get penalized in any way. I didn't have to appear before the state board. They treated it just like any other illness. And what's interesting is my prostate cancer radiation therapist said, I've never seen anybody get depressed on androgen deprivation therapy. And when you look it up, there's a 41% increase in the risk of depression. And when I finally got him to give me the names of a couple people who had had a difficult time but seemed to get better, I called up one of them and said, hell yes, I'm still depressed. 5 years, I'm still on antidepressants, I'm still seeing a psychiatrist, and I can't work. I'm at 60% of function. I can't be a soccer coach anymore, just don't have the energy, all the fatigue and tiredness. So it's real. So my mood stabilized on mirtazapine, now bupropion. So don't kill yourself. Your family won't be the same. Don't suffer alone. Get some help. And for those of you in the Cupid, we had one medical student and one faculty member commit suicide this year, which is too many. One of them didn't show any signs. The other did, the medical student. And it would have been really nice if the other medical students who were around him had recognized this and got him some help. So please, that's the message for today. So that's all I have.